Hello guys, welcome to the next session of integrated series for your NEET and next, and today I think you will be very happy to see the topic which has been requested by so many people, and that's why I thought that I'll definitely come up with this topic before the advent of NEET PG 2021, and this topic is actually integration, but a topic which is basically taken by the ophthalmologist. So I have tried to incorporate all the important things of ocular pharmacology and toxicology, and we'll be talking it in terms of the ophthalmology, and I think we will certainly expect some questions from this aspect, because if you see the last year AIMS paper also, they had asked about, obviously pharmacology was asked, but they had asked one or two questions related to the ocular pharmacology per se. So let's begin with this amazing topic, ocular pharmacology and toxicology, right? Okay, so I'll first take the very basics. What is actually pharmacodynamics and pharmacokinetics? Let's revise our basics and then we'll move forward. So if you go with the pharmacodynamics, it is actually the effect of the drug. So if I talk about the biological and the therapeutic effect of the drug, how that drug is actually acting, pharmacodynamics. Dynamics means activity, pharmaco means drug. So I always have this habit of teaching by splitting the words. I think even if you forget the meaning, you can quickly split the word and the answer is in front of you. So it is, you can say, just the mechanism of action of that drug. Okay. Now if I talk about most of the drugs, they act by binding to the regulatory macromolecules. So these macromolecules are available in the form of neurotransmitters, or we have the hormone receptors or the enzymes. Now if the drug is working at the receptor level, we have got three levels, either it is the neurotransmitters, or it is the hormone receptors, or it is the enzymes. So if this drug is acting at the receptor, the two things can be there, either we have an agonist effect or we have an antagonist effect. All right, right. Now if the drug is acting at the enzyme level, so either it can activate it or it can inhibit it. So either we were having the agonist and antagonist, or here we are having either the activator or the inhibitor, right? Now coming to the next one, next is your pharmacokinetics. Now if you see the pharmacokinetics, there is a small mnemonic that you can easily remember, that is your ADEM. So what is actually pharmacokinetics all about? It is A, D, E and M. A is adsorption, then we have got D for distribution, we have got the E is the excretion of the drug, and M is the metabolism. So while pharmacodynamics was just the mechanism of action of the drug, the pharmacokinetics means how it is taken up in the body, about the adsorption, about the distribution, about the excretion and about the metabolism, right? Now a drug can be delivered to the ocular tissue. Now let's talk about these drugs in terms of the eye. So when I am giving this drug to the eye, I can be giving it locally or I can be giving it systemically. Now let's talk about locally. Locally, what are the things you know? You know the eye drops, you know the ointments, we know the injections, okay, periocular injections, intravitreal injections, intracameral injections, and then systemically. When we give the drug systemically, either it is oral or it is your IV route, right? So these are the different things. Now let's talk about the drug delivery in the eyes. I think this is a very important part, because in all the organs we do not have so many routes of the distribution of the drug as we have in the eye, okay. So one very common thing is your topical drugs. Yes, of course, I can give the drops, I can give the ointments, I can give the gels, okay. Now last time in the AIMS there was a question that a drop is prescribed to the patient and also an ointment is prescribed. So what should be the order? Nurse has come and she has to give the drugs. So what order she should follow? the ointment followed by the drop, drop followed by the ointment, both side by side, or you are first using the drop, wait for 15 minutes, then the ointment. So basically they want you people to have the practical knowledge also, not only what is available in the books. So nowhere it is written in the books that how many minutes you should wait after instilling the drug, or you should give them side by side, but this is common sense and comes by practical knowledge. When you have worked in the wards, you have seen the patients, you have visited the OPD, something like this. Now if you compare here, we have got three consistencies. Drop is particularly the liquid, then I have an ointment and a gel. So gel is obviously a semi-solid, and ointments is again thicker, so we have more viscosity. So if I have a choice between a drop and ointment, I won't give ointment first. Obviously I will give drops first, and if it is feasible, if I have time, then I will give the drop, I'll wait for some time, and then I'll give the ointment, so that I am giving enough time for the absorption of the drop. Second important thing, ointment we usually prefer to give during the night times. What is the reason? This is thicker consistency, increased viscosity, so obviously its effect will be there for a longer time. So during the night, why I cannot expect the patient or his guardian, his or her guardian, to be actually instilling the drop very frequently. It becomes cumbersome and inconvenient. I can easily prescribe the ointment at that time, so that patient can use the ointment and it can carry on its effect throughout the night. The third important thing is that because it is thicker in consistency, it is also going to blur the vision, and due to that blurring of vision, patient may have problem in doing day-to-day life activities during the day. So it's better that you instill that ointment when the patient is asleep. So these are the practical things that you should know between the drops, the ointment and the gels. Alright. Now coming to the second thing, that is your periocular injections. So periocular injections may, if you see, we can give the subconjunctival injections, we can give subtenon injections. I think this is a misprint, it is the subtenon injection. Then we have got the peribulbar injections, retrobulbar. I think peribulbar and retrobulbar you must have already known, because we have the anesthesia where we are giving the peribulbar anesthesia, retrobulbar anesthesia. So that is behind your muscle cone, or you are giving in these peribulbars. Heard this word because though it is one of the entity, but not very common, not very successful, but yes, intracameral means inside the chamber. If I talk about the vitreous, see we have got two segments, one is anterior segment, one is posterior segment. So posterior segment cavity is called as the vitreous cavity. So if I am giving the injection inside this vitreous cavity, that is your intravitreal injection. What if I want to give the injection in the anterior segment? So there I have got two chambers, anterior chamber, posterior chamber. I can give intracameral. So anterior intracameral, posterior intercameral, and then we have got the intravitreal injections, right? And then finally I have got the systemic drugs. So in the systemic drugs, I can give the oral ones, I can give intravenous injections also, intramuscular injections also. So I think oral, intravenous, intramuscular is very well known to you. Intravitreal also you guys know. Subconjunctival injections, peribulbar, retrobulbar, drops, ointment, gels, you know. One of the important things which I think most of you must not be knowing is the intracameral that I have told you. Alright. Now, let us see and concentrate on the factors that influence the local drug penetration into the ocular tissue. What are those factors which are actually responsible and which are actually influencing that how much of the drug is actually penetrating into the ocular tissues? So, the first important thing is the drug concentration and the solubility. So, we know that the drugs are available in the market of different concentrations. So, when I require the better penetration, I am using the more concentration. Higher the concentration, better is the penetration. Like for example, if I talk about the pilocarpine. So pilocarpine mein I have got 1 to 4%. We have pilocarpine 1%, 2%, 3%. To better penetration, I will get with more of the concentration. This is your one thing. Second thing, that you can have is the viscosity. So as I told you that we were having the difference in the viscosity when I was using a drop, I was using a ointment, I was using a gel. So when I am adding this methyl cellulose, polyvinyl alcohol, they are actually increasing the concentration. Why they are increasing the concentration? Because they are increasing the contact time. Which contact time? With the cornea. So you know, anteriorly we have got the cornea. So when I am instilling the drug and it is viscous, it is having more contact time, is more of contact with the cornea, and therefore it will alter the corneal epithelium. Another important thing which will actually affect the penetration is the lipid solubility. Why actually it is influenced by the lipid solubility? Because we have lipids in the epithelium, right? So obviously because I have lipids there, so higher the lipid solubility, more is the penetration. Okay. Then another important thing is whether it is empipathic or not. Empipathic means penetrating the epithelium or the endothelium, then it is penetrating the stroma or not, whether it is hydrophilic or it is not, it is lipophilic or not, it is penetrating the endothelium, epithelium. So all these factors will obviously alter the concentration and the penetration of the drug which is going inside. Now let's talk about the other things which are going to influence. Another important thing is the surfactants. Okay, now what happens? The preservatives, most of the time obviously the drugs that we are using in the form of drops, in the form of gels, in the form of ointments, there are preservatives in them. Okay, so these preservatives are doing what? They alter the cell membrane in the cornea and increase the drug permeability. Now from now on, do one thing: whenever you use any eye drop, I think this is the commonest eye preparation, everybody has one or two eye drops available at home, maybe a simple tobramycin or you know, Atears, Ecotears, any lubricating eye drop. Always try to read the constituents, and there you will get that in the preservative section we have the benzalkonium and thiometsol. So these actually preservatives, they are used in the ocular preparations, they are altering the cell membranes and they are increasing the drug permeability. Okay. Now the second important thing is the pH. What is the normal pH of the tears? That is your 7.4. So what will happen if you are using the drug which is having a very different pH? So there will be reflex watering or reflex tearing. You must have seen that some of the drugs causes a lot of tingling and there is so much of tearing when you instill it. So that is due to the difference in the pH. Another important thing is the drug tonicity. Drug tonicity means what? Now when what you are doing, you are using an alkaloid drug, okay, which is used in a relatively alkaloid medium, the proportion of the unchanged form will increase. And what will happen? Therefore, it will penetrate more. So there are so many factors actually, when that is why we have so many standards for the passage of the drug, for the approval of the drug. So it has to pass all these factors, only then drugs becomes FDA approved to be used there. Alright. Now coming to the topical. So one by one we will be discussing. Let's talk about the topical drugs first. I think topical is the simplest form of the preparation and most convenient form of preparation, and mainly we are using it for the daytime use, because night time it's not very convenient to instill the drug again and again. Now another important thing is that the one drop contains just the 50 microliter. One drop contains 50 microliter, and usually I have seen patients instilling 2-3 drops. They think that one drop will be highly insufficient, but it is completely wrong. Now, if you look at the capacity of the conjunctival sac, it is just 7 to 13 microliter. Now, can you compare here, instead of 50 microns, it is just 7 to 13 microliter. That means even one drop is not going to be absorbed fully because it does not have the capacity. One drop has 50 microliter, and that the drop that can go in the conjunctival sac is just 10 microliter if I go with the average. So a very important thing is that even one drop is more than enough. So keep this in your mind. Always try to explain it to your parents also, your friends, your colleagues, your siblings, that even one drop is more than sufficient, because most of the time you know, they do feel that one drop is not sufficient. Okay, then let me tell you the important way, the right way of instilling this drop. So what you are going to do, I'll show you the picture also. See, what you have to do, you have to hold this conjunctival sac with the help of maybe the index finger. You can stretch it. Okay, so after stretching it, you have to actually pull it forward, so that you know, a pouch kind of thing is formed, something like this, and now it's very easy to instill it. I think it will be better shown here. So we can pull it here, we can make a pouch, and we can instill the drug. This is the proper technique, and ideally one should keep the eyes closed for 5 minutes after instilling the drug, so that better absorption can take place. Alright. So see, in the measures to increase the drug absorption, wait 5 to 10 minutes between the drops. And those who have taken the prescription from me, I hope you must have been remembering this, because many of the students come after the classes that I always say wait for at least 10 minutes before you instill another drug, because you know, the capacity of the conjunctival sac is so less. Even one drop that you have instilled may not have gone inside, and by the time you instill another one, so the first one will all come out. So you should be patient enough when you are dealing with the topical drugs, and very slightly, very calmly you have to instill the drug, wait for 5 to 10 minutes, close your eyes, and you can also compress the lacrimal sac to increase the absorption. You can keep your eyelids closed for 5 minutes, and then you have to instill the drug. So these are, you know, tiny things, little things which actually increases the absorption of the drug. And I think not only the medicos, also the non-medicos should know all these things. So we have to increase the awareness among the people, so that they kind of use the drugs in a right manner. Okay, now coming to the ointments. If I talk about the ointments, ointments are increasing the contact time, right, of the ocular medication to the surface. That means increased contact time with the cornea. But as I told you before also, the vision blurring is a side effect. So it's very cumbersome if you have to use these ointments during the daytime. Another important thing is that these drugs has to be highly lipid soluble, with very little water solubility. So in comparison to the water solubility, the lipid solubility should be very high in cases of ointments. So I hope you people are listening well, and these are the practical things which are expected to be asked in your NEET PG 2021. Alright. Now see how to apply the ointment. Again, you will have to stretch the lower lid, okay, and you have to use it directly. Don't apply it on the hands. We have to use it with the aseptic measures, and you also have to tell the patient how much of it is applied. So we usually tell कि एक चावल के दाने जितना उसको apply करना होता है, as much as a piece of one rice, so that patients could know actually how much quantity they should use, right? Okay, now we come to the periocular injections. Periocular injections. Now, when we feel that we have to go behind the iris lens diaphragm, so that time we cannot rely upon the topical drugs, because these topical drugs are not going behind the iris lens diaphragm. So here we can use different kind of injections, the subconjunctival, subtenon, peribulbar, retrobulbar. I have to give the drugs which are acting on the posterior sides, and topical drugs will hardly do it. So this route bypasses the conjunctival and corneal epithelium, which is good for the drugs with a lower lipid solubility, because those drugs which were having the higher lipid solubility were having the close contact with the cornea, increased contact time was there. Then we can also use the steroids and the local anesthetics. So I think everybody knows that we are using the local anesthetics with the peribulbar injections, with the retrobulbar injections. Steroids we are giving as the injections after the intraocular surgeries we are giving. So this is again again I think a common route that we are using in day-to-day ophthalmology practice. Now first we will concentrate on the periocular injections. So we were having 3 or 4 types of periocular injections. We will take them one by one. The first one was your subconjunctival. Okay, now there are certain drugs whose particle size is pretty large. Okay, so because of that it cannot penetrate the cornea. Okay, so what we can do, if they are not able to penetrate the cornea, we can use the sclera. This will penetrate the sclera. Then second important thing is your subtenon. Subtenon means above the sclera and beneath the tenon. Tenon is a capsule all around the eyeball. Okay, and if you see the shape of your eyeball, it is something like this. It is something like this. So we have a equator here, we have a equator here, right? This whole is a equator. So it could be anterior to the equator, it could be posterior to the equator. Anterior to the equator will be your anterior subtenon, while posterior to the equator will be posterior subtenon. In this way you can go. Then the next one is your retrobulbar. Retrobulbar, you have heard about the retrobulbar anesthesia. Then you have also heard about the retrobulbar optic neuritis. Yes, in the optic neuritis. So in that terms we can use. See, they have given you all the 3 types: optic neuritis, papillitis, posterior uveitis. Then we can also use the anesthesia retrobulbar blocks. Now they are obsolete, and mostly we are going with the peribulbar, but it could be there. And obviously nowadays the most important thing that we are using is the peribulbar anesthesia. So the application where they can be used, I think, is very clear. All right. Okay, now we will talk about the intraocular injections, when you are giving the injections per se inside the eye. So we have an anterior segment, we have a posterior segment. Anterior segment mein we have an anterior chamber and a posterior chamber, and then we have a vitreous cavity. So we can divide it into intracameral and intravitreal. Okay, so intracameral, as I told you, we are not using much, but still in order to document, intracameral acetylcholine we can give during the cataract surgery, right? While intravitreal, we have antibiotics which are given during the endophthalmitis. Then we are giving the steroids. I think we have read this in diabetic retinopathy, where you are giving intravitreal steroids. Triamcinolone we are using for the macular edema. Intravitreal anti-VEGF agents also we are using for diabetic retinopathy. So this was again an important question in the previous exams also, that they used to ask that which of the following drugs can be given by the intravitreal route. So all except kind of a question could also be asked there. All right. Now we come to the sustained release devices. So another thing that we can use in the eyes is the sustained release devices, and the advantage is these are actually sustained release. So they are actually responsible for maintaining a steady state. So you can actually give a device inside the eye which is releasing the drug at a constant velocity, slowly and gradually. So these are actually used at a number of places, like we have Ocusert. Ocusert is delivering the pilocarpine. Then we have got the Timoptic which is delivering the Timolol. Even Gencyclovir devices available, collagen shields are available. Now one important entity where we require the sustained release devices is actually glaucoma. Glaucoma may we have got the diurnal variation of intraocular pressure also, and we need to maintain a steady state concentration of drug inside the eye, so that wherever we feel that IOP can be more, it will keep on suppressing it. And that is why we have got Ocusert, we have got the this Timoptic also. Even other places also use, but this is one of the most important. All right. Now we come to the next one. Now let's discuss the important points regarding the common ocular drugs. So what are the drugs that you have studied till now when we read about the ocular diseases? I think this is the most common: antibiotics. Think about the ulcers. Right, we had the bacterial corneal ulcer, we had the viral corneal ulcer, we had the acanthamoeba corneal ulcer, we had the fungal corneal ulcer. So we have antibacterials also, antivirals also, antifungals also. Then what are the other drugs you are using? Anti-glaucoma drugs you are using. Then uveitis mein what you are using? The Mydriatics and cycloplegics we are using, right? Then posterior segment mein steroids we are using, NSAIDs we are using. Then we have a lot of conjunctivitis, the foreign body sensations where you can use the lubricants, we can even use the diagnostic drugs, you can give the anesthetics, and then you have toxicology. So this is nothing to cram about, just see starting from the first topic to last topic what are the drugs that you read there. Okay. Now, let's go one by one. The first is your antibacterials, that is your antibiotics. So, what are the antibiotics we can use which are available in the form of the eye drops? So, we have penicillins, we have cephalosporins, sulfonamides, tetracycline is there, even chloramphenicol, we have aminoglycosides, fluoroquinolones, we have got vancomycins, macrolides, and usually when we are giving it for the corneal ulcers, we are giving the broad spectrum one, 45 antibiotics, increased concentration, which are activated against both gram positive, gram negative, aerobic, anaerobic. So all these kind of drugs we are using, and see we are instilling the eye drop. When you instill the eye drop, again you have to keep certain things in mind. These eye drops, once open, once broken seals should not be bought, and once you are opening the seal, you should always write the date upon it, because you should discard it after 30 days. Means after opening you should not use it beyond 30 days, and always store in a cool dry place. You don't have to refrigerate it, you don't have to keep it under the direct sunlight. When you instill this eye drop, it should not be coming in contact with the cornea or any other structure, it should be from above. So these are again the basic instructions, because in the hospitals the nurses will instill the drugs, or residents will instill the drug, or their attendants, but at home obviously all the time they are not in in vigilance, and they are instilling the drugs. So these basic instructions should always be given to the patients as well as their attendants. Now coming to the further details of the antibiotics, okay, where you are using them. So we are using these antibiotics by so many routes, like I can use it topically. Topically I am using these drugs for a lot of bacterial infections, for as a prophylaxis also before the intraocular surgeries we are using them. Then for the oral ones, orally whenever you have got the severe infections, like we have the preseptal cellulitis, we have cellulitis, we have got this cavernous sinus thrombosis. So wherever we have got a lot of infections, even in the pre-operative cataract surgery patients, we are using both the topical as well as the oral antibiotics, not just the topical one, because we cannot take a chance. And as I always say, endophthalmitis in the eye is just the end of the eye, and nobody wants ever that a surgery which we are doing for the betterment of the visual acuity is landed up in the endophthalmitis. So though the chance of endophthalmitis, the chance of infection is very less, just 0.2 to 0.3%, but still we do not take a chance, and we give the antibiotics in all the form. Then we also use intravenously. So orally we are using for the less severe, that is your preseptal cellulitis. When you have even more severe like orbital cellulitis, we can give this for the orbital cellulitis we can use it for intravenous, and at times when we have orbital cellulitis we also give orally and IV, because many a times you do not know exactly and you cannot take that chance and you start the empirical treatment. Then we can also use the intravitreally. Now this is very important. I think everybody knows that in the endophthalmitis we start the antibiotics by all the routes: oral, topical, systemic, intravitreal, everything, intravenous also, and the most important out of all of them is the intravitreal, and then you wait for 48 to 72 hours. If there is no betterment, if there is no improvement, we go for the vitrectomy. Alright. Now see, these are the conditions of the eye. We have orbital cellulitis, we have got endophthalmitis, and I think when you see such kind of questions in the clinical scenarios, you actually jump towards the antibiotics. All right. Now, talking about the specific antibiotic for the organisms. Now, at your level, okay, we have discussed that we give mixed aerobic, anaerobic and broad spectrum antibiotics. But if I talk very particularly, so let's talk about the sulfonamides. Now, I think everybody knows from the pharma knowledge what is the mechanism of action. So, we will be just discussing it in brief. So, you know that there are bacteria which are synthesizing their own folic acid, okay, and in this PABA is a constituent, and this PABA actually has to be taken from medium. So, when we give these sulfonamides, what is the mechanism of action? They are the analogues of PABA, and therefore what they are doing, they are binding there, and due to which PABA is not able to bind, and you are inhibiting the synthesis of folate. So, basically they are the inhibitors, they are competing it. Now, instead of the PABA, the sulfonamides will go at that place. So, what they are doing is, they are the competitive inhibitors with the PABA, and the PABA that was required to produce the folic acid, which is not being produced now. So, they altered a folate, okay, which is metabolically injurious is there. So, these are actually forming, instead of the folate, now what is forming when these sulfonamides are combining? So, they form the dihydrotoroic acid, which is conjugating with the glutamic acid to produce the dihydrofolic acid. So, this is actually the metabolically injurious, and this is how we are giving. But when you give the sulfonamides, you should be very careful, because there are so many patients who are actually sensitive to sulfonamides or allergic to sulfonamides, and we should not give certain group of drugs. For example, we have got your carbonic anhydrase inhibitors. Alright. Now, let's talk about the uses. So, where do you give these sulfonamides? We are giving in the chlamydial infections. Now, chlamydial infections, where we have trachoma also, that is your blinding trachoma. We have got inclusion conjunctivitis. Then we are also giving in the toxoplasmosis. So, whatever form of conjunctivitis you get, whether you get this kind of pannus you are getting, and Sago-grain follicles, and the Herbert pits, or you get the inclusion conjunctivitis, something like this, or you are getting the chorioretinitis patch in cases of toxoplasmosis, you are going to think about the sulfonamides. Alright. Now, the next important group of drugs is actually the cephalosporins. So, we do often give the cephalosporins for a more important and a more severe kind of infections in ophthalmology, and you know that these cephalosporins are your bactericidal beta-lactam antibiotics, and they are derived from the fungus. So, these antibiotics are very strong, very good and effective ones, but the problem is that there is no activity against lame. Lame means L-A-M-E. What is this lame now? So, it is a mnemonic here. We have got what you called as the L for listeria, A for atypicals like mycoplasma, chlamydia, then you have got methicillin resistant Staph aureus, and then you have got E, that is your enterococci. So, I think this is again an important point where a question could be asked that cephalosporins are not effective. So, only exception is that you have got the ceftobiprole, which is actually is acting against the methicillin resistant, otherwise they are not acting. Okay. Now, let us quickly see the different category of the drugs. We have first generation, second generation, third, fourth and fifth, and I think you must be knowing that which of the names of the cephalosporins from these different generations you need to learn. As far as ophthalmology is concerned, I cannot say any one. Okay, so whatever is important from your pharma perspective or your other medicine perspective, you can remember those names, and if at all you remember all, then that is the best one. Okay, now coming to this. Now, if you look at the quick review, how can you remember? So, we have first generation, second generation and third generation. So basically when we have the first generation, we are actually using it for gram positive cocci, like we have the cefazolone. In the second generation we have got for the gram negative, like we have got the cefuroxime, and for the third generation we have got the gram negative, this is ceftriaxone. So basically what we are using most of the time is the third generation, that is ceftriaxone. And whenever we start suspecting the endophthalmitis and we are starting the systemic antibiotics, till now we have not given the intravitreal, you are waiting. So it is always safest to start with the third generation, that is your ceftriaxone. Alright. If I talk about the side effects, they are always there. So we have allergic reactions, we have neutropenias, the thrombocytopenias. Yes, they are severe, but nevertheless we don't have choice always. Okay. Now we have the aminoglycosides. So what is they doing? So aminoglycosides are actually the bacterial protein synthesis inhibitors. So they are inhibiting the protein synthesis, not able to grow therefore, and that is why they are mainly acting against the gram negative bacilli. So most of the time what we read in cases of ulcers, we are starting the empirical treatment. Empirical treatment means just you are giving the broad spectrum, both gram positive, gram negative, you are not waiting for the culture reports, because most of the time patient is already started with some treatment, and if I want to do the culture, I will have to first stop the drugs for 48 hours, then I'll ask the patient to do the culture, and then we will be coming with the reports, and then we start with the treatment. So obviously I cannot stop the drugs for so much of time and unnecessarily increase the risk. That is why we give the empirical treatment. But if we do have the time and if we are going with the standard protocol, you can give the treatment after the culture and sensitivity. So for this we have got what you called as gentamicin 0.3%. Remember the concentration for the simple drugs, that could be asked. Tobramycin we have got 1% and neomycin 0.3 to 0.5%. They won't be asking every concentration, but yes, these basic drugs which are commonly asked, it's better you can remember them. Okay. Now the second one is your tetracycline. Tetracycline is again inhibiting the protein synthesis, and tetracycline, as you know, we are using for the chlamydia, trachoma also. This is actually both for gram positive and gram negative. We have got fungus and even the chlamydia. In terms of ophthalmology, especially important, this tetracycline is for the chlamydia, where you are also using the single drug regimen like azithromycin. Now another important drug is your chloramphenicol. Chloramphenicol is also inhibiting the protein synthesis. It's a broad spectrum drug, and again that is why it is important. Both tetracycline and chloramphenicol are broad spectrum. They are effective against both gram positive, gram negative as well as chlamydia, and they are coming in the percentage of 0.5%, both the eye drops and ointment. Even once I think they had even asked the question that which of the following is available as a drops or ointment. So at times they are asking such kind of a question, right? Now coming to the antibiotics. Now if I talk about the trachoma, which is one of the infection that is causing the leading blindness in India. So one infection that can be responsible for the blindness is a trachoma, and it is the most common infection which is causing blindness in India. It can be treated by the topical and systemic tetracycline. We have erythromycin, and as I told you, we also have the single drug regimen. We also have the single drug regimen with the help of systemic azithromycin. Then another important thing is the bacterial keratitis or the bacterial corneal ulcers. When you are treating the bacterial corneal ulcers, we are giving the fortified drugs. Fortified drugs means you are increasing the concentration by adding the injections to it. So we can use the penicillins, the vancomycins, cephalosporins, aminoglycosides, fluoroquinolone. So these are the drugs that we are using. But if I talk about the conjunctivitis, or nevertheless conjunctivitis is often less severe in cases of in comparison to the keratitis, and these infections are usually self-limited, but we can use the topical erythromycin, again aminoglycosides, fluoroquinolones, chloramphenikols, same drugs could be used. So this was about your antibiotics. Now I am going in a faster pace, not very slowly, so that you do not waste much of the time before your NEET PG 2021, and quickly you can go through this video. Now the second important thing is your antivirals. If I talk about the antivirals, I think you will jump upon acyclovir. So this is the most common antiviral that we do discuss, and that is your 3%. So remember your herpes simplex and herpes zoster. So herpes simplex and herpes zoster mein topical what we are giving is a 3% medicine 5 times a day. And when it comes to herpes zoster, where I am using the tablet form mein it is 800 milligram, again 5 times a day. Even we can also use intravenous for the herpes zoster retinitis. So you know that herpes simplex is simple one and zoster is a severe one. So when it is causing the retinitis, we can even use the intravenous variety. Then apart from this, we have lot of drugs like we have idoxuridine, vidarabine, cytarabine, trifluorthymidine, ganciclovir. But yes, acyclovir and ganciclovir are the most important ones, and most of the time the indication is the herpes zoster, or we have the viral uveitis. There also we can use it. Again, they are available in the ointment form and in the form of the tablets. Alright. So, one important form of the viral retinitis is the cytomegalovirus retinitis. Can you see and tell me which kind of retinitis is the cytomegalovirus? Can be of pizza pie appearance, granular appearance, brush fire kind of appearance. So, can you tell me out of the three which kind? So, this is a question for you. Write it in the comment section. Which kind of retinitis is the this? CMV retinitis is the most common, you know, retinitis that is occurring in HIV patients. We have cotton wool spots, and this particular one is very specific for HIV, and you have to tell me in the comment section that which kind of retinitis it is. Alright. Then another kind of viral disease where we can be using the antivirals is the dendritic ulcer. Dendritic ulcer, that is very typical of the herpes simplex, typical, you know, arborizing patterns we can get there. So, there also we can use it. Then we have got the antifungals. Now, if I come to the antifungals may obviously we have fungal corneal ulcer, we have fungal retinitis and endophthalmitis. Endophthalmitis is again very important indication where you are using the antifungals. Commonly available are the paulines, we have imidazoles, flucytosine, and I think you must have be remembering that in the fungal corneal ulcers we are using the amphotericin B, netamycin, nystatin. So, what was the drug of choice for your filamentous fungus? That was your netamycin. In cases of the yeast-like fungus, we were using the amphotericin B with the nystatin. Then we have imidazoles like miconazole, ketoconazole, fluconazole. We have got the flucytosine also. So, a lot of drugs are there. And this is your typical picture of the fungal corneal ulcer, dry looking, greyish with the elevated margins, finger-like projections, rolled out edges, multiple satellite lesions and whatnot. So, if you are getting something like this, think about the fungal corneal ulcer and think about giving the antifungals. Then we have got the Mydriatics and cycloplegics. I think nobody can forget this, that this is the treatment of choice of the acute anterior uveitis. We have two things here, one is the Mydriatics, one is the cycloplegics. Mydriatics means they are dilating the pupil, cycloplegics means paralysis. So, basically they are doing two things, they are dilating the pupil and they are also, you know, giving relax to the ciliary muscle. So, they are actually giving full relief to the ciliary muscle spasm, and that is why they are considered to be the drug of choice of acute anterior uveitis. And then we have the classifications. So, we have got three kind in terms of their classification. We can have short acting, intermediate and long acting. So, you people already know longest acting is your atropine, the duration of action is also longest, while shortest acting is the tropicamide. Intermediate mein we have cyclopentolate and homatropine. Then one which is only a Mydriatic, not a cycloplegic, is your phenylephrine. So, where you are using it? You are using it in the uveitis, you are also using it in cases of the corneal ulcers in order to give relief to the pain, because there is a lot of ciliary muscle spasm. Then we can also use it for refraction. So, these are the important indications where you are using the Mydriatics as well as cycloplegics. Alright. Next is your anti-glaucoma drugs. Now, though we have already taken a separate lecture in our, you know, the ophthalmology, pharmacology integrated lecture. So, just a brief I will give here. Anti-glaucoma drugs may we have got the beta blockers, we have non-selective timolol, selective one is bitoxolol. So, they are actually decreasing the aqueous humor formation, and the most important is the timolol, but timolol is actually contraindicated in the cardiopulmonary diseases, and there we can give the bitoxolol. So, that you know. Now, side effects may there are a lot of side effects, and side effect is again important in terms of the questions. May bradycardia, A for anxiety, B for bradycardia, you have sweating. Yes, and then you see the ocular में irritation is there, headache, frontal headache, cyst formation can be there, follicular conjunctivitis. So here you can easily remember it with the ABCD, that was your allergic follicular conjunctivitis. A, B is for blurring of vision, C is for corneal sensation decrease, and D is for dryness. These are very, very important side effects that you are getting with the beta blockers. Okay. Then next one, next if you see the carbonic anhydrase inhibitor. So you know we have got topical, we have got systemic. Topical with dorzolamide, we have brinzolamide. In the systemic we have acetazolamide, methazolamide, and they are inhibiting the enzyme carbonic anhydrase, and therefore again the decrease of the aqueous formation, and again lot of side effects we have got paresthesias, lot of increased frequency of urination, GI disturbances is there, we have got the hypokalemias, and due to this, you know, at times the usage of these drugs is also limited. Alright. Now, if you go with the hyperosmotic agents, we know that mannitol or acetazolamide are there, but if I talk about the mannitol, which are the hyperosmotic agents, in the hyperosmotic agents we do not have acetazolamide, but in the emergency cases we use both mannitol and the acetazolamide. Now when it comes to the mannitol, it is very, very important because you know it's a diuretic, it is not an anti-glaucoma drug per se. It is just, you know, shifting the fluid from the vitreous cavity to the ECF, so that temporarily we are bringing the intraocular pressure low. So it's a very good drug when you have to immediately decrease the intraocular pressure from a very high level. So there you can use it, but of course it has a side effect because it is causing the volume overload. It is shifting the fluid. So because of that volume overload, it is contraindicated in those conditions where we already have the volume overload. It could be your renal failure, it could be your heart failure, so you won't use it. So what is the drug of choice? If I talk about the drug of choice, we know it is the prostaglandins, especially the latanoprost, and remember the concentration 0.005%. It is actually increasing the uveoscleral outflow. It's a good drug, but again we have got many side effects. We have already discussed the side effects: the intraocular inflammation, hypertrichosis, we have trichomegaly, we have got pigmentations, we have got cysts. So all these things are there, and that is why its usage is again limited. So this was about the anti-glaucoma drugs. Now we come to the anti-inflammatory drugs. Again we cannot, you know, underestimate the importance of the anti-inflammatory drugs, because there are many diseases in the eye which are having the inflammation. So if you see here, we can divide these anti-inflammatory drugs broadly into two categories. We have got the good steroids, and because you know steroids is a double-edged sword, we can use it many places, while we are also having the side effect at many places. So we also have the second choice, which is your non-steroidal anti-inflammatory drugs. Now these steroids again can be divided into short acting, intermediate acting, and long acting. I think you must have learned this in your pharma. Again, this is important because I have again seen time and again they are asking the question on steroids regarding their potency, regarding their efficacy, regarding their side effects also. So when it comes to short acting, we have got what? We have got the hydrocortisone, when we have cortisone and prednisolone, right? Then if I talk about the intermediate, we have got two. One is triamcinolone, one is the fluprednisolone. While if I am talking of the long acting, that is the ones that we are using in obs-in-gynae, that is your dexamethasone and betamethasone. Now if you go to the relative potency, so relative potency may I have used this table from the Parsons, which is available in chapter number 10. Okay, so you can see this, and I won't be reading everything here, but yes, if you see here, the comparison is very, very important, because at times they will give you 4 drugs from this and they say which one of the them is least potent or having the most potency, most anti-inflammatory effect, least side effect. So you should know this order, and especially important is the fluoromethalon, dexamethasone, loteprednol, prednisolone, betamethasone, hydrocortisone. I won't say that others are not important, but these many drugs are very, very important because of their maximum usage. So you should know the comparative efficacy of these drugs, and you should also remember that the least potent is the fluoromethalon, and that is why it has the least of the side effects, and that is why you know, whenever we require the steroids in the ophthalmology, we do actually begin with this fluoromethalon. All right. Now indications are too many, starting from the topical you are using for every kind of inflammation, allergic conjunctivitis, scleritis, uveitis, keratitis, and then when you are having a lot of surgeries we do require for the inflammation. When you have got the systemic we will use when we cannot benefit the patient with the topical drug. So when it is behind the lens, like posterior uveitis, we have optic neuritis, and then very important thing is a rejection. There you have to give it. Alright. So never give steroids. I think this is not complete without giving you this statutory warning that never give steroids if you are suspecting some active infection. If you are not giving steroid at one place, that could be forgiven, but if you are giving a steroid at one place where infection is there or could be there, that will not be forgiven. So we have got so many things. It could be a case of allergic conjunctivitis where you are giving the steroids. It could be a case of episcleritis where you are giving the steroids. Then we have the anterior uveitis where you are giving the steroids. Yes, we have lot of contraindication, and as I say, contraindications are always more important in comparison to the indications here. We have fungal infections, glaucomas, because you know that we have got the GTCS, means topical steroids can induce the glaucoma. So in glaucoma, whenever you have epithelial defect, they can penetrate. We have herpetic epithelial keratitis, even systemic, because you know they are a lot of complications of the steroids. They are causing the hyperglycemia, they are causing the osteoporosis. So all these places we are not giving them. They can induce ulcers, they can precipitate the ulcers. Then you have got, you know, end organ damage, heart failure, renal failure. So again, you know, these are your integrated things where ophthalmology, pharmacology, medicine, all these things could be asked in an integrated fashion. Okay. Now, if you come to the ocular side effects, yes, I told you we have GTCS, topical steroids causes more of glaucoma, systemic steroids causes more of cataract, more chances of infection, they will delay the wound healing, and that is the reason that we are not giving them in glaucoma, we are not giving them for long term in any patient, we do not want to give it in infection or because it delays the healing and all these things. Now, at all the places where, you know, steroids are contraindicated, there we can go with the NSAIDs, or you feel that even it will be treated by the NSAIDs, it's not that severe, there also you can start with this. So topically, what are the NSAIDs we can use? We have the flurbiprofen, we have indomethacin, we have ketorolac. All these drugs are also, you know, used in cases of allergic conjunctivitis. Indomethacin we are using for CME, we can use it for episcleritis, scleritis, uveitis. Cystoid macular edema is very important, and in every case of cataract surgery, many consultants prefer to give indomethacin SR, that is sustained release, in every case, so that we can avoid the risk of cystoid macular edema. Then we give preoperatively before the cataract surgery in order to maintain the dilatation of the pupil, and preservative will be same, that is your benzalkonium chloride. Now, these are the important concentrations of the drugs which are actually used. If you go with the topical drugs, we have got the indomethacin, that is your 0.1%. I hope it is visible. Then we have flurbiprofen 0.3%, ketorolac 0.5%, diclofenac 0.1%. Don't learn these because at your level I think these many are okay, otherwise you won't be able to learn any of them. Then we come to the systemic one. Systemic mein most of the names you know, I think paracetamol, diclofenac, aceclofenac, ketorolac, ibuprofen, flurbiprofen, naproxen, mefenamic acid. So I think you already know this. The next is your ocular lubricants. Now, though you know lubricants are not very serious kind of drugs, but certainly in eye they play a very major role, and we are giving them in ocular irritation, dry eye. So many commercially available tear substitutes are there, and I think all of you should keep one eye drop handy, because all of us are having so much of screen time, especially when our exams are so near. So they are available in the form of Refresh Tears, Tear Plus, Moisol, Ocuvet, Gentil, Eco Tears, Ad Tears. I think the very fancy names are there, and we are using the preservative also in the stabilized oxychloro complex here. Now next we will take with the ocular diagnostic drugs. Now after you have seen the therapeutics, mostly the drugs that we are using for the therapeutic purposes, the drugs are there in the eye which we are using for the diagnostic purpose also. So one very important drug, I will not say drug, actually it is a dye. So we are using the fluorescein dye in the form of drops, or we have got the strips which are impregnated with the fluorescein dye, and that is basically 2% sodium salt. I think this is one of the dyes that we are using most commonly in the ophthalmology for staining the corneal abrasions. Then we are using it in the applanation tonometry when you get the Myers for detecting any of the wound leak. You are using it for the Segel's test. We are using it. Then we are using it for any NLD obstruction. Jones dye test mein we are using it, and you are also using it for the angiography. I think this is an amazing question as a short note also for your internal exams, as well as obviously it is important for your NEET PG. One of the important things is that you have to take certain caution because it stains the contact lens. Then fluorescein drops can be contaminated with the pseudomonas. So every time you are using something in the eye, the risk of contamination is always very high. Then if you see here, these are the examples when we have stained the ulcers with the fluorescein. You have got fluorescein angiography, right? Then another dye is your rose Bengal stain. This is actually staining the devitalized epithelium, and the dose that we are using is 1%. What are the uses? The use is very important. You are using it in a very dry eye and also in herpetic keratitis. Now if you remember, we have got the dendritic pattern there. So what is happening in the dendritic pattern? We have got tree-like arborizing pattern along with the knobs, something like this. So you have got two things here. One thing is the knobs here. These are called as the knobs, and this is actually called as the floor. So both the places are actually dyed with a separate stain. For the knobs we are using this rose Bengal dye, while F for F. So F for floor, floor is stained with the fluorescein dye with a simple mnemonic that F for floor, F for the fluorescein dye you can use, and the knobs are by the rose Bengal stain, they can be stained. Now coming up to the anesthetics. So first we take with the local anesthetics. So local anesthetics may we are using the topical drugs, like we have got the proparacaine, tetracaine, and there are a lot of uses. I think so many procedures you have already learned where we are using these anesthetics, like in applanation tonometry, gonioscopies, when you want to remove the foreign bodies, or when you want to remove the sutures. Then there are certain patients who do not actually cooperate, or their pain threshold is very less. They are not able to open up their eyes because of pain, and there are a lot of adverse effects. Obviously you cannot take it for granted. It can be toxic to epithelium, and we can have the allergic reaction, so you don't actually overuse it. Coming up with the orbital infiltration, we can have peribulbar or retrobulbar. It is causing anesthesia as well as the akinesia, and what we are using very common solutions, lidocaine 2%, bupivacaine 0.5%. I think this combination is a very standard combination, and you should know the name of the drugs along with their concentration, 2% lidocaine and 0.5% bupivacaine. Alright. Now if you look at the pictures, this is your orbital infiltration, and you know that we have got two kind of anesthesias. One is your peribulbar, one is your retrobulbar. So accordingly we are using the injections. If you are using the peribulbar, we have to use two, one on the upper eyelid, one in the lower eyelid. If you are giving the retrobulbar, then we have got a single one. Coming to the ocular toxicology, last but not the least, and we have got complications of topical administration we have, and mostly the questions also are asked from this. Like we can have one very important thing, we can have the mechanical injury from the bottle. Now these are the things which are accidental and we do not think about them, but they are very common. When you are instilling the drug and you are end up rubbing that tip of the bottle to the cornea, there can be corneal abrasions. Then as far as the epinephrine is concerned, pigmentation is very common. There could be damage with the topical anesthetics. We can have hypersensitivity. So hypersensitivity ke liye atropine, neomycin, gentamicin, this is very common. Then we have the systemic effects like topical phenylephrine can increase the BP. Again, a very important thing, because many times students do ask us that can hypertensive people take phenylephrine? So no, means most of the time we think that the topical drug will not have any effect on systemic hypertension, but this is one drug which is a severe vasoconstrictor, and that is why, if you remember, I told you this in the refraction also, that if a person is having a systemic hypertension, don't give phenylephrine, we give only the tropicamide. Then talking about the amiodarone. Now amiodarone is one drug which is frequently asked, so I think anything which is related with amiodarone is important. So this is a cardiac arrhythmia drug, and you know it as a cause of optic neuritis. It is causing the visual field defects, it is causing the bilateral optic disc edema. Then you also know as one of the drugs in pica. What was pica? Do you remember pica? Pica was the drugs which were causing the vortex keratopathy. We were having this phenothiazines, indomethacin, C for chloroquine, and A for amiodarone. So this A for amiodarone is also responsible for your vortex keratopathy. Amiodarone is important as a cause of optic neuritis. Amiodarone is also important as a cause of cornea verticillata, right? This is your cornea verticillata. Can you see the vertical striations? These are the whorl-like deposits which are present on the epithelium, and this person mostly is either asymptomatic or may have some amount of glare that can be due to these deposits on the epithelium. So that is called as cornea verticillata, right? Then another important drug is a digitalis. Now digitalis is one drug which is very important as far as your cardiovascular system is concerned in the medicine, in the pharma, and it actually causes the chromatopsia, so yellow colored vision. And many of times I bet you will be able to solve this question because of this yellow colored vision. They will give you a long clinical question, and then they say that they'll end up giving one drug which is causing the yellow color vision, and you just know that it is digitalis, right? Okay. Next is your chloroquine. Now chloroquine I think is a talk of the town starting from your last year, and there are so many questions which have been asked related to it. We have chloroquine, we have hydroxychloroquine, and I took a separate session on your bullseye maculopathy also. I think that is again very important because bullseye maculopathy is important, and nowadays chloroquine and hydrochloroquine is important, so we can get a question related to it. And you know it is used in malaria, rheumatoid arthritis, SLE, so many of the orthopedicians, physicians, they are using it. And chloroquine can cause the vortex keratopathy. Chloroquine can also cause bullseye maculopathy. So I will not go into the details here because we have separately given you bullseye maculopathy, right? So this is the standard lesion, which is also called as the annular benign concentric macular dystrophy or the bullseye maculopathy, which is caused by both chloroquine as well as hydroxychloroquine. So do remember, you have to learn everything about it. We have discussed it before, right? Then the next important drug is the chlorpromazine, which is a psychiatric drug. Now here we can have a question which is integrated between the ophthalmology as well as psychiatry. They can give you a question that all of the following drugs can be causing the posterior subcapsular cataract except a person having psychiatric illness, because a psychiatric illness person may be having the chlorpromazine, and this chlorpromazine actually is responsible for causing the anterior subcapsular cataract and not the posterior subcapsular cataract. So it is causing the punctate epithelial opacities on the cornea, on the lens also. So it is ASC, anterior subcapsular cataract. Really it is symptomatic, and an important thing is that it is reversible with the discontinuation. So when you are giving this chloroquine to a person and it is causing the retinopathy, that is not reversible. When you are giving chloroquine and it is causing the keratopathy, that is cornea verticillata, that is reversible. Similarly, when you are giving the chlorpromazine and it is causing these punctate opacities, it is also reversible. Then the next important drug is your thioridazine, which is also a psychiatric drug, and this is very important in terms of your salt and pepper retinitis. So, salt and pepper retinitis is again an important DD that could be asked, and out of all the causes, if I talk about the drugs, then phenothiazine, thioridazine, this is important drug that is causing your salt and pepper retinitis. It looks something like this. Can you see? We have got black and white mottling of the retina that resembles your salt and pepper appearance. Then the next important drug is the ethambutol that you are using as a ATT. It causes a dose related optic neuropathy. Now, I think everybody knows that it causes the optic neuritis, optic neuropathy, but you should know that that is causing dose related optic neuropathy, and it is reversible. Most of the time it is reversible. Occasionally, permanent visual damage can take place, but mostly it is reversible.